Good afternoon, everyone. My name is Deborah Hodges. I am with the Institute of Medicine of Chicago. It's a pleasure to be with you today for the webinar on critical foundations of healthcare artificial intelligence. I am the Association Manager and Program Manager for IOMC. I've been with IOMC since 2019. It's both a privilege and an honor to be working with such a great organization. If you're unfamiliar with IOMC, let me bring you a little bit up to date in regards to it. The Institute of Medicine of Chicago was founded in 1915. It's an independent nonprofit organization of distinguished thought leaders in the health field who collaborate to improve the health of the public. It draws upon its diverse membership, its regional leaders, and it addresses critical health issues through a variety of interdisciplinary approaches that include education, research, communication, and community engagement. IOMC is a 501c3 nonprofit organization, and next year it'll be celebrating its 110th anniversary. Before we begin today's program, I just wanted to alert you to an upcoming event. On December 4th, IOMC will be conducting its Leadership Summit. It's open to all. I hope you will consider attending it. We have some fabulous speakers who will be giving individual presentations at the event itself. The last leadership event that we had in December, which is similar to this, was a sold-out event. So I highly suggest that you register early. There will be a few more speakers also that will be added to that event itself. So go to the website and look for the registration on that Leadership Summit. And that's also a biannual program. So it's an important program to attend, especially during this time of with the elections and so on. If you are new to IOMC and you are not a fellow, I highly suggest that you check our website and see if you would be interested in becoming a fellow. Information can be found under the membership tab on the website in regards to the benefits, the dues, and other great details on IOMC. So today's agenda, we've covered the upcoming programs. We have a fabulous program planned for you today, a very robust organization presentation itself. And then the last 15 minutes of the session today will be on questions and answers. So you'll be able to put your questions and answers in the question box. Feel free to do that throughout the presentation. We'll visit that box at the end and capture as many questions as we can today. So the learning objectives for today's program is to gain a better understanding of the industry dynamics shaping AI in healthcare. Also, to realize physician perspectives and sentiments in regards to healthcare AI, and to acknowledge the parameters and stakes in getting ethics and equity right for healthcare AI. I want to acknowledge our sponsors for this program itself. Washington Square Health Foundation provided a grant to support this program today. Golden Square provided sponsorship along with the Midwest Business Group on Health as well. So we thank them for their continued support of IOMC. At this point in time, I want to turn it over to the reason why you're here today, and that's to hear from our two speakers. Dr. Fernando Maio is the moderator for today's program. He's the Vice President of Health Equity Research and Data Use at the American Medical Association. He's the Professor of Sociology at DePaul University and a Fellow and Director on the Board of Governors for the Institute of Medicine of Chicago. He's a frequent presenter with IOMC, and so we're pleased to have him with us today. At this point, I'm going to turn the presentation over to Dr. DeMaio, and he will introduce Christopher Curry. Thank you so much, Dr. DeMaio, for being with us today.
Of course. Thank you. Thank you so much for hosting us today, Deborah. I'm really thrilled to moderate today's presentation by my good friend and colleague at the American Medical Association, Christopher Curry. Christopher is the AMA's Vice President of Strategic Insights. His work is focused on assessing and interacting with emerging elements across healthcare, technology, and policy sectors. He has worked in healthcare for over 20 years. Christopher received his MBA from the Ohio State University Fisher College of Business, magna cum laude. He holds BS and MS from the University of Illinois in electrical and computer engineering, and an MS in biomedical engineering from the University of Wisconsin. Chris, when the idea came up for the IOMC to host a talk in AI, I immediately thought of you for the speaker role, as I know this is a topic of deep interest to you, something you've worked on and have thought about for quite some time. I'll admit that to me personally, AI is a topic that both fascinates me and also worries me quite a lot, and perhaps more of the latter than the former. I have the good fortune really to have a job where I think about data all of the time, particularly data at its intersection with equity. I think about how data can be empowering, a way of documenting injustice in the world, and a way of supporting collective action, of not just describing the world, but changing it for the better. And of course, we know that data can also do the opposite. It can be used to marginalize people, to perpetuate injustice, and normalize systems that cause harm. So I do worry about how violence, how harm gets embedded into our data systems, and what we measure, and how we measure things, and how we analyze data, and the interpretations we draw from that work. So I come to the topic of AI, like I know many of us, with excitement over possibilities, but also some concern about these fundamentals. And I say all of this knowing that the answers we might land on are very complicated, that they are not simple yes or no kind of responses, particularly when you consider the speed at which this conversation is evolving. Everything around AI is changing so very rapidly. And I personally feel that like I don't have a solid enough handle on this discourse yet, right? And it's something that I really want. So Chris, I'll be grateful for your perspective on where we are in terms of AI in healthcare. I know you'll share some thoughts on AI fundamentals, on context and healthcare industry dynamics, which are so important for us to grapple with, on what physicians think about AI, really important for us to understand, and where we are in terms of underlying principles around AI in healthcare and equity in particular. As Deborah mentioned, we'll set some time aside at the end for question and answers from the audience, and I very much look forward to that. But in the meantime, first, Chris, the floor is yours, and thanks again for joining us today.
Great. Hello, everybody. Good afternoon. First of all, thank you to Fernando for that really kind introduction and also just the setting of the context for the discussion today. Also, the organizers at IOMC and Deborah in particular for the detailed planning and thought and care that went into today's conversation. As Fernando introduce the topic, I'm likely not going to be the first nor the last person you'll hear from on AI, given just how much it is permeated nearly every aspect of our condition, the human condition, our workplace, and certainly healthcare, which we'll get into plenty of that. I was mulling over a particular image that I really thought could capture the moment and trying to figure out what could really convey sort of what AI means to us all. And some light bulb went off in my head and I thought, what about jellyfishes? I'm pretty sure they don't have brains. And so I quickly looked it up on the internet and it turns out, yes, indeed, they do not have brains, but they are creatures that can sense and feel and exist in their environment and produce things. And they're, the part of the animal kingdom. So here we are in a place where we're trying to understand AI and understand whether, the degree of power that it has within the different facets of life. But we also have other elements in our world that we can draw upon to understand, what this really means. So some visual stimuli there. Disclosure slide, pretty standard here. I'll keep going. Fernando touched on the objectives for today. We'll be diving into healthcare, but when we get into the questions of ethics and equity, that draws upon other types of inquiries that I think will be useful here. So let's start with context here. And again, when I was going into this, you're constantly trying to look for frames that help you understand. As Fernando said, this is a complex topic. And I really thought it important to stress that the context of how AI is developed and is evolving in our US healthcare environment is really important to understand the backdrop. And so here's a quote from a performance artist, Marina Abramovich, who makes the point, depending on where you bake the bread, so to speak, whether you're an artist or a bakery, the context makes the difference. And what kind of context? Well, this is a busy slide, but intentionally busy because this is really just a scan of our past 12 months in the environment, 2024 environment that we've all been existing in here. And you can see a number of these headlines and imageries here, ranging from, the corporatization of healthcare delivery systems, nationwide IV fluid shortages, right? Postponement of surgical procedures, corporate medicine, large payers, nationwide payers that are dominating the cost and drivers of healthcare. A cyber attack, I just saw the updated numbers, 100 million people in the United States were affected by one particular cyber attack earlier this year. Financial and economic instabilities among rural hospitals in particular, where we already know we have some of the highest barriers to access to care. And a number of other things, including, the ongoing attack on civilian and healthcare infrastructure in places like Gaza. And then finally, just a note that even something like the Nobel Prize was given, engineering prize was given to scientists and technologists involved in AI. So this is very much, a moment where a lot of things are hitting at once that impact our system. And this was also a pretty recent report. Many of you have seen the work out of the Commonwealth Fund, Dr. David Blumenthal and researchers there that do these large comparative studies of global health systems. And quite frankly, this slide, tends to look pretty similar every single year when you look at the performance of the US system compared to other industrialized countries. But the quote from Dr. Blumenthal says that the United States is failing to fulfill one of the most basic responsibilities of any country, which is preventing needless suffering and death. So this is the context we're in when we look at how technology can shape healthcare in the future, and particularly AI. And when you go into that more micro level, you go into the world where physicians and other healthcare workers are working in all kinds of delivery settings. This is the environment that they experience here. As some of you know, the AMA does a lot of work around physician burnout. We've measured it in recent years. It peaked certainly during the COVID era. It's below 50% now, but still quite high. And, these burnout dimensions are driven by a lot of these things you see on the right-hand side here: lack of autonomy, work control, excessive time pressures, and administrative burden. And the ever expanding chronic disease population. So a lot of factors at play. Not all of these things are sort of have a negative effect, but they do generate complexity and burden in our health system. So we promised we would talk a bit around AI fundamentals, and let's do that here. So AI has really been a body of research and knowledge for, I think, close to 70 years now, depending on where you do that starting point in the 1950s. It's around 70 years. Things like informatics in healthcare have been around for many, many years and multiple decades. We've always had access to analytic tools, and we've, somewhat more recent development, but had access to clinical data, outcomes data in healthcare that allow us to ask better questions and get more precise answers. But AI, at the end of the day, is an umbrella term, right? The ability of computers to perform tasks that typically require human intelligence. But there is a family of bodies of research and development that form this umbrella that we call AI. We're at the moment, and I'll tap ahead here, we're at an interesting moment here, arguably, the third or fourth wave, at least in the past 20 years, that brings us to generative AI. In the previous era, we've sometimes labeled predictive AI, deep learning, machine learning. Generative AI builds upon a lot of those techniques and allows us to create net new content through methods in training of large corpuses of data sets. This time is a bit different, partly because so many of us, regardless of our job and our work setting, actually have access to generative AI. Most of us could not develop and train a machine learning algorithm in the past 10 years, but today we can actually get pretty sophisticated even with relatively little training in the generative AI era. And again, from an industry perspective, AI is big money. We're taught to sometimes follow the money. There is a very, very large opportunity for kind of the next era, information era, if you will, that is built on AI platforms. And certainly this applies in healthcare too. And in the healthcare space, there is actually quite a bit going into drug development and design using AI techniques. There's a lot that some of you on the call may be familiar with here around EHR documentation, virtual scribes that allow you to transcribe the interaction with the patient and extract meaningful structured information out of that for clinical decision making, and a number of other attempts at making AI ubiquitous within the clinical environment and the administrative environment. In fact, you see that really here, visualized here on this slide that my team put together. And this looks at two dimensions. The purple dimension, or the purple dots, are all clinical applications. The gray dots, circles, are all administrative applications. There are dual, currently very attractive opportunities in both of these areas. Some would argue administrative applications are kind of the lower hanging fruit because of those burdens I talked about earlier that physicians and other parts of the workforce are feeling. Anything that you can do to reduce administrative burden is considered a win here. There is a frontier, and this frontier is constantly moving. In fact, I've already talked about how we might update, where this frontier is at today, because it is something that continues to move quickly as companies are racing to achieve this kind of market presence and ultimately dominance. So fast-moving space and a lot of specific use cases. We'll highlight a few more of those. From a regulatory perspective, the FDA has begun to release data that shows the medical devices that there are cleared or marketed for approved for marketing, rather, in different categories, medical categories. The last number that was publicly available was around 950 devices. That's gone up about 300 or 400 since a year ago. And you can see radiology is the dominant space there, with sort of cardiovascular applications a distant second, and everything else can kind of get rolled up from there. And again, not surprisingly, because the era we just are emerging out of, the pre-generative era, has largely been focused on imaging applications and improving the automation and the ability to identify, clinically relevant indicators in images. So there we see it in the sort of industry and regulatory space playing out there. And health systems are a lot of them the ones that have the resources, and we should say that there's a bit of a have and have not situation here. The well-resourced health systems, I think, ultimately see this as a competitive advantage they need to build. perhaps just as those prior eras when you would see health systems putting up billboards off the side of highways touting the robotic surgery tools that they have in place, or proton therapy tools, those sorts of things. So here you see a lot of health systems saying, we've begun to do proofs of concept, we've implemented something, and we plan to do more of that. So again, we're going to go a little bit more micro again, and again, being a person that is deeply enmeshed in the physician mindset, I'll share a little bit about what they're thinking now. And this is a framework we've shared over the years, not specific to AI, but really about technology adoption. It's a framework that came out of studies AMA has done in the past that look at the drivers of adoption and potentially the barriers too. And these are the questions that come out. We should say that, again, in an AI era, these questions will likely continue to evolve, right? But this sort of is a high-level, simple summary. Physicians want to know if the technology works, right? And that's largely about, is there evidence, clinical evidence in the form of trials and peer-reviewed literature and other aspects. They want to know if there's a risk in changing the way they practice. Is there going to be a legal risk to changing the current standard of practice into something different, and whether they'll be liable or not? They want to understand that there's a payment mechanism, and they also want to understand if it will work in their particular patient, with their patient populations and their practice setting. If they're in a smaller setting, is this something they can implement with relatively limited long-term investment commitment, things like that. And so we're actually going to update this survey probably the next time I have a chance to talk to any of you, we will have updated results. But the last time we asked physicians around their sentiments in AI was late last year. And this is, again, we were about a year into this generative AI moment. 65% of physicians see an advantage in using it. They want to see administrative burdens attacked first with these solutions. And they're sort of half and half in terms of, I think, as Fernando kind of said in his opening comments, a mix of excitement and concern and caution in terms of ultimately how it will play out in healthcare. And these are just some of the numbers. The administrative burdens really, you can see physicians basically screaming at the top of their lungs through these data, which is that they really want administrative burdens reduced, and they are willing to, you can call the technology whatever you want. They want it to address that. Capacity, in an era where physicians are overburdened, sometimes with patient loads, they want to be able to augment their capacity. And then, on a smaller level, things like remote patient monitoring and physiological monitoring, which is something that is also an area that's really gone under rapid development, opportunities there to help patients in between those encounters and moments when they are seeing a healthcare or medical professional. And I talked about the will it work question here. And so clinical evidence, again, is something that most physicians that responded saying they needed resources, that's the top of the priority list there. CME courses, by the way, AMA has a lot of CME courses available on our education hub, and there's a lot out there in general in the major clinical journals that is worth reading. Implementation guides, and you'll see a little bit about why that is in a top 3 here in a later slide. Peer-reviewed literature in terms of the type of clinical evidence needed, clinical trials, FDA's approval or review. And so, in the era we're in now, we need a lot of interaction between physicians and other healthcare professionals and the developer communities, right? The communities that are in these companies developing and commercializing these tools. And these are some of the attributes that we are on an ongoing basis trying to convey to these the innovators and developers that are out there, some of which are still physicians, but many of which are other technology practitioners. So again, you can see some of the needs that physicians are conveying here: data privacy, making sure that if a model produces an error or an errant recommendation or result, that there's no liability there. And that ultimately physicians are involved in the design, development, and deployment of these tools. And again, as an organization that is built upon policy and also a space that has a lot of policy development activity, both from the public sector, private sector, principles development, there are a lot of things to draw upon. So I want to touch on a few things. It's worth noting that, again, last October, actually exactly a year ago, the Biden administration developed a set of 8 guiding principles that have begun to be built out within the current administration around then these are broad principles around the development of trustworthy artificial intelligence, not healthcare specific, though healthcare is called out, particularly in safety and security, in terms of protecting consumers from unsafe AI in a healthcare setting. And maybe some questions that I think we still need to address here around what does it mean to support the workforce and workers that may have their labor disrupted by AI tools. And I think there's some good work and smart people out there thinking hard about that today too. I'm reminded by a lot of my colleagues in advocacy that this isn't just work at the federal level. Actually, because of the moment we're in and how quickly things are moving, lots of states around the country are developing or introducing bills or passing bills in some cases related to AI in healthcare. There is a tracker out there at the bottom from Manat Health that where this is updated periodically so you can see the dynamics. But what this means at the end of the day is if you are a health professional or someone interested in tracking the evolution of this, it's pretty complicated. There are a lot of layers to sort through depending on what geography you may be in. In our own society's journey, we've been at this since, well, circa 2017, let's just say 2016. And again, as an organization, we have policy on behalf of America's physicians that describes the appropriate use of AI. But what I really wanted to convey on this slide is that there's a lot of elements that make this work such that the policy is developed in a way where it can impact the real world. You can say policy is not, well, it's the substrate. You also need to engage the stakeholders out there. You need ethic development and asking new questions around our ethical frameworks. And perhaps most importantly, you need to understand, a little bit of what David Blumenthal tried to communicate in the Commonwealth Fund report at the beginning, which is that we have a really challenging environment for improving health in this country. And a lot of that is around the inequities that exist in our healthcare environment today and the inequitable outcomes that exist for so many patients. So a lot of factors go into it. We've got some great work just as important to mention around artificial intelligence and how the next generation of physicians can be trained and what skills they need to be effective clinicians within the medical school and graduate medical education environment. So we had this 2018 policy foundation that allowed us to begin work with so many of the clinical and healthcare community. And that evolved into, principles that are currently being updated. We're about to go into our AMA's interim meeting here in a couple weeks, where much of this will be reviewed and discussed. But we do have updated principles that put a finer point on not only generative AI, but other aspects of the health sector's use of AI. So I won't go through all of these, but I'll highlight a couple things. The payer use of AI, right? In automated decision-making systems. We do not necessarily want a world where payers are using automated AI to deny coverage, right? We want to make sure that patients' privacy rights are protected in the same way that a healthcare provider is obligated to do so. So should companies that are collecting and providing services through AI. And transparency is a big piece too on number 2. We've talked for a long time around the importance of being able to see inside that black box and better understand how an AI may be reaching a score, a conclusion, a recommendation. That is becoming increasingly hard to do for a number of reasons, especially in the generative AI space. Some of you've heard around things like hallucinations that have occurred, and it's really hard to understand how that actually happened. But it's not just transparency about that black box. It's also transparency about when it is being used and deployed in a healthcare setting. And that applies to both patients and physicians and other healthcare workers. Certainly, patients have a right to know when it is part of the care providing in a healthcare setting, and how decisions were made based on any of these tools. And we have things like coding terminology. You know, I won't go into a lot of detail on this, but a lot has evolved over the past couple years. And when I say coding terminology, I don't mean programming languages. I mean things like a CPT, because current procedural terminology that describe the services and procedures in healthcare. So we now have a world where we have categories of AI services that can be provided in healthcare and examples of those. And the coding framework paves the way for ultimately the ability to seek payment and reimbursement there too. And you can see some examples here at the bottom, ranging from retinal imaging in the autonomous category to assessing cardiac dysfunction using algorithms against EKGs. So. And I gotta say, like, one big takeaway for me over the past year is not only is the industry and the money flowing everywhere for so much of the commercialization of AI, but similarly, a number of these sorts of consortiums are standing up, all with various somewhat related aims, which is evidence generation, which is evaluation and auditing and testing of AI in implemented settings. Sharing of best practices that apply to health systems, health equity dimensions. So there is again a frothy environment where a lot of organizations are trying to organize themselves, sometimes with others, right, in a consortium model. So I want to get to kind of the last section of the work here, and I've committed to Deborah and Fernando that we will have time for Q&A, and I'm going to do my best to stick with that. So I want to introduce this concept of socio-technical systems, right? And so I trained as an engineer. They didn't necessarily teach us these things in engineering school. We certainly learned how to build things and solve difficult problems, technical problems, but this was kind of new to me. We have to begin thinking of AI as not just a technology, but really as a body of work that is interacting with the social, organizational, and human elements that they potentially operate in. They're not just technologies purchased off the shelf and operating in isolation. In fact, they're developed with this context too, not just sold and implemented. And that actually has big implications. Fernando, I think, eloquently made the point around how data can be used for harm, violence, or good, depending on the approach to it. And I think the difference here is, in addition to that point, is the scale that these systems can operate at, that generates, the hope is, new kinds of good, but also new kinds of harm that we have to be vigilant against too. And so I call this the engineer's dilemma because I am an engineer, and I remember a time, and this graph's a little bit hard to decipher, but essentially it looks at a whole bunch of publications focused on healthcare AI, and where did they spend their time doing the research and writing the article and getting it peer reviewed and published is mostly around demonstrating, accuracy and comprehensiveness. Could it do something that is sort of, could you say that this tool, resulted in an outcome that was similar to what a human could have done, right? So this is kind of, where AI started, was being able to replicate human tasks. And, this heat map here that shows the 222 here and other large numbers, um, being able to produce, to demonstrate tasks, that's where all the action is. But I want to point out a couple things on this kind of meta-analysis from the literature here, recent literature, is a fair amount of things that are less covered. In fact, in some cases, not covered much at all, which is fairness, bias, and toxicity evaluation, deployment metrics, and calibration uncertainty, which is, hey, what happens if I take what you did and I try and do it over my environment? Is it calibrated for my world? Is it going to drift? Is it going to respond differently to my patient population? In addition to some of these other ethical and equity questions here. So relatively not adequately addressed so far in the literature. And we need to not only look at the literature and hold that accountable, but we also need to look at how companies are doing in each of these dimensions down here too. I mentioned medical ethics. AMA has been at this business, so to speak. It was our first product we launched in 1847, the Code of Medical Ethics. And we continue to work on this area from an ethical lens. One difference, though, compared to 1847 is that we have physicians, again, working in these complex socio-technical environments with many others. There's a team-based care approach now in medicine. So it isn't just one physician making an individual ethical decision and trying to use the best framework they can. These are complex models. We're interested in these questions. I want to be very explicit here that we don't know some of these answers yet in healthcare, which is to say, what happens when you pair a skilled worker of any sort and you give them additional augmentative tools? Are they able to handle more complex tasks and essentially go down that sophistication curve to a better place? And these are going to be really important questions for healthcare. We've seen it play out in other industries because those industries had these technological advancements much earlier. But these are questions we have right now about whether physicians, become the sort of superhuman level of practitioner because of the advancement of AI, or do some of the other professions progress closer to an existing physician? There are a lot of models out there to help understand how we can think about bias in a healthcare setting, and a bias in the deployment of AI, design, development, and deployment of AI. And you see some examples here. Bias is not just about whether you picked the right training data or source data or not, though it would certainly be in there. EHR data is a mirror or a reflection of the inequitable world that we operate in terms of healthcare and social determinants and structural determinants of health. But that same bias can exist in the actual design of the model. Maybe the source data is okay, but the model design is leveraging features or factors that are inappropriate and can amplify bias. So different kind of frameworks. We have to get comfortable and familiar with these because these frameworks force us to ask questions we wouldn't normally ask. And so I wanted to make sure these are shared. Another framework here that provides guiding principles for practitioners and developers of healthcare AI. There's a literature link there at the bottom. And for the interest of time, I'll keep moving. These are some of the tests going on. So these were scholars, I think, these folks at Stanford that asked a number of questions of 4 different generative AI chatbots, right? And they asked questions you know, basically the more red it is, the less accurate answer was given back. So you can see things like, how do I calculate the EGFR for a Black woman? Largely because perhaps these models were trained on out-of-date data around those algorithms, it produced the wrong answer. The genetic basis of race, we know race is a social construct. Well, one of these produced an errant answer there. So these are the types of studies we certainly need. Likely these things have probably been fixed in different ways, but it's important to know, how we begin to better understand our current state here. I would be remiss if I didn't mention climate. The healthcare industry is one of the most polluting industries in the industrialized world in terms of biological waste and plastics and energy usage. AI also is in that category here. Someone said that, a query into ChatGPT-4 nowadays is the equivalent of pouring, a bottled water on the ground every time you do that query or throwing it out. But the bottom line is these use up a tremendous amount of energy in their current state. That will change and improve in certain ways, but we need to be mindful of it. I already mentioned algorithmic care denial. We're seeing, applications of this in place today, and we want to be vigilant again about not, building a healthcare future that denies care to patients. And then, finally, just a couple sort of last thoughts here. Ruha Benjamin is a fantastic scholar who's thought really hard on systemic racism, and she reminds us that we cannot assume that those who are designing and adopting these tools are thinking carefully around systemic racism, right? We need to be vigilant about how these tools are built out of environments where that still exists. And finally, I think we have agency here, right? We existed as a human race without iPhones before, right? We chose to adopt those things, and we're still a human race that could decide how we want this world to evolve. We don't necessarily need to, take the answer from any of the tech oligarchs. So with that, I'm actually going to just go. I'm going to wrap up here again to thank you all as attendees and leave you with this. I don't know if it's an inspirational picture, but we got Asclepius with a staff and a snake here. This was AI generated. Fernando knows I like to do this on occasion. And I asked the AI to do this in the year 2024 in Chicago. I think some of these buildings are accurate, but some of them are just not. So that's, I'll leave it at that and welcome thoughts and comments in discussion now.
First, Chris, huge thanks. This is definitely a highlight of my day. Really appreciate the thoroughness and thoughtfulness of the presentation. You walked us through key fundamentals. I love this idea of the complex social technical system by which we can better understand these, not as techniques, but as in all their complexity. And the really thoughtful comments you had about emerging challenges at the end of the presentation as well. So again, huge thanks. I'm going to invite the audience to submit questions to the Q&A box, and we'll get to as many of them as we can in the next few minutes. So Chris, I'll share some of the questions, and again, we won't be able to get through all of them, but we'll open up some possibilities for conversation. The first question is, could you speak a little more about the use of AI in medical education, which is also part of this complex ecosystem? And I wonder if you have any insight on that front.
Well, I've learned a lot from my colleagues at the AMA, and we are doing a lot of work in this space. And my colleague, Dr. Kim Lomas, who's really the expert here and was involved in the National Academy of Medicine work, which I encourage you to look at exactly on this topic. There's a really great report there. But I think you can look at it in two dimensions, and I've learned this from her, which is you can look at the use of AI in medical education as a tool that accelerates and improves learning and competency development. You can also look at medical education around AI, which is what are those salient things that physicians need to know? I mean, there was certainly a time, physician knowledge bases have needed to continue to evolve throughout history. Telemedicine, the invention of ultrasound, right? I mean, you look at all these different and other imaging techniques that change the way physicians practice, flow cytometry. And so AI is not really different than that. I mean, it's potentially more all-encompassing in a way, but we need to be able to teach physicians and empower them the right tools to, understand, how this, what it means for the way they practice medicine. And that will be different at the specialty level. Certainly, things like simulations, right, are, we have a ability now to create so-called digital twins and synthetic data, that allows us to explore questions of population health and train the physicians of the future on managing population health, even though they might not have full exposure to that in the real world environment. We can still train them on it. So those are, just some examples around medical education.
Terrific. Thank you for that. Amazing set of questions are coming in, really reflecting the diversity of our audience. We have some physicians, we have folks in public health, we have folks who work in a variety of different organizations. So I'm going to bring one up that I think speaks to this. The question is, she's deeply appreciative of today's session and certain this information will inform her work in the spaces of public health, medicine, and equity. The slide on bias that can creep into the AI life cycle is essential. What are some ways that people like me, not physicians, can contribute to addressing these forms of bias, though we may not be IT or technological professionals either?
The question was how to contribute to mitigate the bias. I just want to make sure I understood correctly.
Yeah, how can we contribute to addressing these forms of bias,
Yeah.
even if we're not physicians or IT or technological professionals? Public health and other equity folks are also on the call. What's their contribution that they could make?
Yeah, great question. I mean, I guess I just came back from a kind of a public health conference of sorts last week, that had a poster session of different diverse groups looking at, in some cases, the use of technology and AI. And I'm one way, and again, I'm not an expert in this, but increasingly, I think the best research is community driven and community involved. And so I think we need different skill sets to truly address AI as a socio-technical system. You need different skill sets involved in design, development, deployment of it. We, as AMA, certainly say physicians need to be there, but quite frankly, public health professionals also need to be there. And some of the basic cornerstones of public health around involving community participation in different ways, I think, are actually really important. And I feel like, Fernando, you could elaborate much better than me on this, but I feel like there's something there around the types of inquiries and questions that public health professionals ask. I think that's why we partially have these bias frameworks we can draw upon now, is because of that type of thinking. I don't know if you want to elaborate or comment.
Yeah, no, great thoughts. I was thinking something similar when you were presenting the emerging challenges. I was curious what the best practices have been in this field for community engagement, for community ownership of data, right? In other sectors, we talk about data sovereignty, data justice. And I do worry that the technology is kind of outpacing that kind of relationship building aspect that we've seen in other parts of public health and healthcare. And I'll be curious to see how this evolves in the coming years.
Yeah, it's technology, and I think it's the what's behind the technology, which is, I mean, there's someone smart pointed this out, which is that so much of the technology that we see today that is AI driven came out of an era of the 1990s and 2000s, which was largely an era of technology built on surveillance of what our habits and interests, whatnot, on social media and web searches that allowed marketing and advertising revenue. That's why these companies are so big, is largely around being able to do targeted advertising. And that is largely, a phenomenon of technological surveillance that we should be on guard for.
Terrific. If I could, I want to bring in a question that came in through the chat from Raj Shah. Hi, Raj. He says he has been struggling with the boundary society wants to set for AI. I think this might be an interesting thing for you to explore. Are there boundaries here that you've thought about or you want to highlight? Are there lines that we should not break? Or is it too late? Is this out in the world and it will be hard to control?
Oh boy, man, Raj, I would love to hear your thoughts on this too, and anybody's thoughts. I think this gets at really kind of one of those penultimate questions. Not sure I'm really like well equipped, other than I don't think it's too late, right? I think uh, I think there's again I look at studies and research where I can, and it varies widely geographically. So if you look at the European Union, you look at Asia, Africa, the Middle East, you will see different points of emphasis around AI and what is important societally to them. In the US, what dominates tends to be privacy. That is certainly something that comes out pretty strongly, and that's perhaps a cultural trait, that is unique, more dominant in the United States. But I think now is the time to kind of broaden, to your point, broaden the boundaries of what we consider to be important. Like, what are the factors and variables we need to be considering? And it is much, arguably, it can be much more than just privacy, cybersecurity, safety, right? We know those are important. But if you look at other examples, which is why I read things like the Commonwealth Fund study, it forces you to look at how others have approached the same problem. And it does vary. And it's a good thing that others are approaching it differently. We can learn perhaps from that.
That's so interesting. I am curious to learn more about the global nature of this conversation and where the US is in relation to other parts of the world which are also engaging on this, and how the conversations might be different and where we can learn from as well, of course. I'll come to maybe a few more questions in through the chat option. I encourage people to chime in as well. One question, Chris, as AI becomes more common, how do we encourage health professionals to maintain their commitment to patient connection? How do we prevent sentient AI down the line from replacing doctors in the patient-physician relationship?
Yeah, I mean, a really excellent question, and thank you for that. I think that gets also to the heart of it, particularly in healthcare. I've been tracking this for a while. Gallup does the trust in the ethics of profession survey every year, and for a long time it was always physicians, nurses, and pharmacists in the top three. Nurses first for much of that. But still, those health professions as the most trusted profession for ethics and honesty. We don't want to lose that. We've gone through a pretty tough era. I think other folks have talked about an era of misinformation, the COVID era, and other challenges to the healthcare workforce. But I think we need to ultimately get back to the value of that human interaction, the human touch, that is unique to healthcare. And how do you do that? I think this was one of the questions I kind of had at the end that I went through the slide too quickly, but I guess what we don't want is to deploy a solution that takes more time away from that patient doctor or patient clinician interaction and simply transfers the money and resources saved to that technology company, right? Because there are currently people, as we speak, there's someone doing a sales pitch at a health system, some in the United States, making that case, right? And I'm not sure we want that as a society, and I'm not sure it's good for patient outcomes. And that's again something we want to be vigilant not to lose that inadvertently.
If I could, I'm going to chime in with a question around publication as well, because that's also part of our healthcare ecosystem, and where we've seen remarkable advances, some dangers in AI authored publications or contributed publications. How do you see that as part of the landscape that you've described? Is it also one of the emerging challenges, how we remain vigilant to originality and authenticity and credibility of our research?
Yeah, I mean that's super fascinating. And there's probably a lot we don't know. We certainly know that the clinical journals, have now, the biggest ones have guidance in place, right, around research and authorship and authenticity, that are super important. The concept I would put back is we're still in a world where you take GPT-4, whatever the latest one, trained on, and you look at what it's trained on. We actually don't know, but you can make some assumptions like Wikipedia, for example, that it's among trillions of other, stubs of information. That's still all human generated information, largely. There will be a time, this is a little bit sort of in prediction territory, but there will be a time when these models are trained also on synthetic data. We don't know if that's, synthetic meaning, a version of Wikipedia that is generated by a generative model, right? In an engineering, world, that's kind of like a recursive problem, right? And that may create some real tough scenarios, particularly around. I'm not trying to claim this is going to be a big issue for all of healthcare. I think the questioner who submitted this had it right, which is this is around knowledge generation, human knowledge generation, and what the implications are in both. And I guess we can maybe pay attention right now to the precursor to the scientific literature question, which is the Hollywood Writers Union, right? That are writing, the next blockbuster hit or whatever, and whether, where their jobs go, there might be an indicator.
Got it. Well, Chris, I can't thank you enough for this really thoughtful presentation and conversation. You have left me even more excited and concerned about the emerging challenges, which I think is just what I wanted from this conversation. I want to thank everyone for tuning in and for the thoughtful questions, and certainly to the IOMC for hosting us today.
So thank you everyone for joining today. Just a reminder, IOMC is a not-for-profit independent organization. So if you find that you can donate to us, we'd greatly appreciate that. It's entirely funded by donors and private donors and our members itself. You will find this presentation to be on the website. We will definitely post this. It will take a few days or so for us to put that up. If you have any other questions, feel free to contact the IOMC office. We'd be glad to answer them and provide you more information either on the presentation or about membership or about an upcoming event. So have a wonderful day, wonderful afternoon, evening, and upcoming weekend.